And for patient with complicated diverticulitis by an abscess required percutaneous drainage. After subsiding of the attack, you go directly for elective resection?
No, never.
Yeah.
Never. I don't understand people that do that. People who do that are dangerous. They're doing that on purpose to operate on people. Unless they're getting recurring problems, I don't understand that. What's the point? If I have a car crash, will you tell me afterwards you're going to stop me driving to prevent me from having a crash?
But the reason guideline from the American Society recommended elective resection after subsiding of the attack.
I don't wish to be impertinent, but they are completely and utterly wrong, and they're doing that for money. They are not doing that because this is a fantastically good idea. And there are other parts of the world who are usually interested in doing that, and when you look at them, you'll see what's the difference. The difference is these are places where people are paid per operation. It is not a good idea. There's no requirement to do it. It's a discussion with the patient to say, that was dangerous, wasn't it? That was difficult. You're not likely to get it again. You've got a 15% chance to get it again. 15. That's all. So if I operate to prevent you getting it, I'm wasting your time 85% of the time. That's like playing Russian roulette with a gun. Would you? I wouldn't.
Thank you, Professor De Swinter. Actually, it's very interesting. And I'll talk about the lavage. Why we are not using lavage? Because we are dealing with a different concept of patients. Because if you don't have a continuous source of contamination, you can do the lavage. You can do it even percutaneous. You can do it like the old tank of catheter. But the problem is to go to the OR and have the operation. If he's a self-payer, why? You let me in the operation twice, I'll pay twice, I stay longer. So the blame of the patient, which keeps us not doing the lavage frequently. But if we discuss this problem with our patient, tell them this will be your best chance to avoid a stoma, this can be acceptable to them because we have different culture. As you mentioned, you have a lot of cultures now in the Ireland and the UK. Different peoples behave differently, and I think the problem not in the part of science. You mentioned it's clear, it's decreases the incidence of complications in stoma, but the problem is in acceptance of the community and the patients and even the third payer. Why you pushed him to the OR twice, I'll pay twice. So we have to explain to them before we operate and have some of the orientation lectures. But I'll mention something about the question, the last question about if you have an abscess, you have to operate. No, I agree with you that it's not essential. But if the patient keep having these symptoms of diverticulitis, or even in uncomplicated diverticulitis, I'm faced every few months with a patient, uncomplicated diverticulitis, but he can't live with his diverticulitis, I send him to the physician and I tell them I will never operate except after the permission of the physician that you have no chance with medical treatment. Thank you. Professor Mohammed Nado.
Thank you for a nice and interesting presentation. But you mentioned that one of the indication of the surgery is symptomatic stricture.
Yes.
What about asymptomatic stricture? I find it in a follow-up of the patient, okay, with colonoscopy, something like that.
If you can pass it with a colonoscope, it doesn't need to be operated on.
Okay, and
simple as that.
If I had, I don't know what is the risk of malignancy in this stricture. I don't know. Okay, I took a biopsy. It is a negative biopsy. I'm sure that from this biopsy, this stricture isn't a malignant stricture. And after a certain time, 3, 5, 4 months, what about this stricture if it increased? I am the one who's, the patient will blame me about leaving this stricture. And what I mean with a symptomatic stricture, okay, I am a patient with diverticular disease and I have small stricture. Even I don't have a stricture, okay, I had a sort of abdominal pain, okay, discomfort, not a pain. This is a symptom of a stricture or a symptom of a diverticular disease, I don't know.
Not a stricture, no. You would, if you have a stricture, you will have obstructing symptoms.
Yeah. Okay.
Oftentimes when you do a scope on a patient, you have fixity of the sigmoid, which makes it difficult to do when you do a colonoscope.
Okay.
But in the absence of absolute obstructing symptoms, I personally would not operate on someone.
Okay, no. You will tell the patient what to do, to follow up this structure or just if there is a symptom?
My suggestion personal and professional, is do not make a catastrophe of something which is not a catastrophe. If you live long enough in surgery, you will do elective operations on someone with benign disease with just a simple stricture like that. They will leak, they will have horrible problems, they will have... In my practice, where I fix other people's enterocutaneous fistulas, they're always because of diverticular operations that I would not have done in the beginning. It's dangerous. It's not the same as cancer because it totally distorts the anatomy, exactly as you're describing. So I think it's extremely dangerous to do that. I think there are circumstances where you cannot be sure that the stricture is diverticular. Maybe laparoscoping a patient will be reasonable, but to be sure that they don't have... I've seen ovarian pathology in the concavity of the pelvis pull diverticula in, causing a stricture, but it progressed over time, and the patient got worse pain over time, and the patient had bad tumor markers. So it's not always easy. But in a patient with no symptoms, I personally do not think you can justify doing an operation.
Okay, thank you.
Okay, definitely I agree with this and that. If the patient is not in need of surgery, so you don't need to do it 100%. Thanks, Des, for this presentation. And I'm sure that there'll be a lot of discussions on the side discussions later on.